High ankle sprain physical therapy exercises. This objective examination aims to gain valuable information on how the symptoms have come about and what is causing them. Locking, popping, giving way. Type of shoes and their wear patterns. Functional limitations. Does the pain presentation lie within a dermatomal region? How does walking on different terrain affect swelling? If runners, what is the surface, distance, frequency, level, i.e. competitive or recreational? Mechanism of injury. This gives you clues as to which structures may have been stressed. Gym type, intensity, duration. Knowing the history gives clues as to the structures affected. Mechanism of injury is extremely important. If you can work out the force of the injury, this gives you clues on likely stretched, damaged structures. Inversion injury may suggest damage to tissue on the lateral aspect of the ankle, and perhaps a lateral ligament complex. Eversion injury may suggest medial tissues may be affected, and large direct trauma may suggest fracture. Make sure you consider back referral too. If there was no history of trauma to the ankle and it has FAROM, look closer at the site of pain. Does the patient's pain lie in a dermatomal pattern? Are reflexes and myotomes normal? Immediate swelling and bruising usually indicates significant trauma and may require X-ray to rule fractures, bone bruises, or an MRI to investigate integrity of the ligaments. Achilles tendinopathy, chronic, coming on gradually over time, continuing to undergo exercise despite discomfort. Repetitive loading, athletic and non-athletic population. Achilles tendinitis, acute, crepitus and/or tenderness in the Achilles tendon region. Increased symptoms with increased load, i.e. running, jumping, climbing stairs. Rest decreases symptoms. Achilles tendon rupture. HO rapid eccentric loading, i.e. running, jumping, sprinting, stair climbing. Severe pain in TAW. May report hearing, pop, or feeling posterior impact. Positive Thompson test, unable to heal, raise. Tenderness over rupture site, gapping between ends of ruptured tendon. Plantar fasciitis. Pain eases with a few steps. Insidious onset, gradually worsening. Change of shoes, i.e. long walk and wellies. Ankle sprain. HO trauma, inversion, eversion injury. Variable pain, depending on severity and function. Excessive movement and complete rupture of ligaments. Immediate bruising, swelling. Stress fracture. Insidious onset of symptoms. Overuse injury. Intense training program with high mileage ++. Specific localized tenderness over bone. Eases with rest. Compartment syndrome, can be chronic or acute. Acute muscle weakness, paresthesia, vascular compromise, disproportionate pain to a passive stretch, immediate and referral needed. Chronic, symptoms ease with rest. Same symptoms as acute but less intense, dramatic, nil vascular compromise. Syndesmosis sprain. External rotational force or hyperdorsiflexion force to foot ankle. Pain on tibial tuberosity. Tenderness over posterior tibiofibular ligament and ATFL. Also consider turf toe. Tarsal tunnel syndrome. Morton's neuroma. DVT. These are the special questions which may indicate that something more sinister may be going on. Patients should be referred immediately back to the GP with your concerns noted. Ask a senior's advice on the severity of these symptoms and whether an A&E referral is more appropriate. Mechanism of injury is important here. What force was exerted through the leg? Was it enough for a tibia-femur fracture? Loss of pulses in the foot may indicate vascular compromise due to a fracture. Fractures can lead to fatty embolisms, therefore warrant immediate A&E referral. Bilateral pins and needles or numbness in the ul. Problems with bowel and bladder function where the patient is unable to feel themselves going to the toilet. Incontinence. Paresthesia in the groin region. Loss of pulses in the vascular compromise. Obvious deformity. The objective examination gives you quantifiable measures to rule out what structures are involved and to reassess after treatment to determine improvement, deterioration. For example, documenting that a lady has 50% ankle inversion will allow you to reassess at her next treatment session and monitor improvement or deterioration. This should help guide you on whether a treatment has been effective and can help confirm a diagnosis. Observation, gait, posture, heel walking, L4-S1, toe walking, S1-S2, heel raise. Posture, forefoot, rear foot, valgus, varus. AROM, ankle DF 10 to 15 degrees, ankle PF 45 to 55 degrees, ankle inversion 30 to 40 degrees, ankle eversion 15 to 25 degrees. Measure swelling, effusion, tape measure. Prom. Mitomes. Reflexes, patella, L3-4, ankle jerk, S1, Dubinsky, clonus. Sensation, dermatomes. Palpation, dorsal pedal and posterior tibial artery pulses, soft tissue, bony landmarks. PA spinous processes, 2R, back pathology. PA transverse processes, 2R, back pathology. Strength PF, DF, INV, EVE. Try to establish the structure involved. Pain at the end of the day after work may suggest structures that are stressed as the day goes on. Pain in morning could be due to inflammation, i.e. OA. However, if the pain is easier in the morning, this could be due to reduced swelling due to rest and elevation overnight. Does it ease with a few steps? Is it due to tight fascia, muscles which ease as they warm up? Poor quality of movement, is the muscle jerking or shaky, which could indicate pain inhibition or fatigue. Throughout movements, where does the patient feel their pain? Is the patient weak in a specific range, or does the pain increase with soft tissue impingement, i.e. end of range DF? Does the patient present with significant guarding, apprehension and unwillingness to move? Pins and needles of paresthesia, numbness in the lower limb. This normally suggests a neural element, which may be coming from the lumbar spine or compression of the nerve somewhere along its course. If you press on a structure and this reproduces the patient's symptoms, this may suggest referred pain is occurring. Single heel raise tests ankle PF strength. Anterior drawer test tests integrity of ATFL. Kleiger's test tests integrity of deltoid ligament. Squeeze tests integrity of interosseous ligament, syndesmotic ankle sprain. Homan sign, deep vein thrombophlebitis. Stress tests integrity of interosseous ligament, syndesmotic ankle sprain. Taylor tilt, INV stress tests integrity of calcaneofibular ligament. Thompson's test tests integrity of the Achilles tendon. Vibration test, stress fractures. Test for Morton's neuroma. Physical therapy to improve strength and conditioning. Athletes are always looking for that competitive edge. Being a split second faster, a little stronger and having better endurance can mean a big difference when it comes to competitive athletics, as games and races often come down to photo finishes and last-second plays. Today, many physical therapy practices now include strength and conditioning clinics for everyone from high school football players to Major League Baseball players, to help individuals reduce the risk of injury and improve their agility, endurance and strength. A major part of modern sports medicine is preventative techniques that help athletes stretch and train properly to avoid common sports injuries such as sprains and strains. One way to help athletes avoid injury and maximize their athletic skills is through conditioning. No one simply takes to the field or court and jumps right into mid-season form. Athletes need to work their bodies into shape, and most of the grueling conditioning is done prior to the start of the season. Physical therapists and strength and conditioning coaches can be very helpful in planning training programs that will improve balance, speed, strength, explosiveness, stability and agility. Through specially designed programs including core strengthening and plyometric exercises, therapists and coaches can help athletes train their bodies to be prepared for specific athletic activities that will improve their performance and reduce the chance of injury. While many people think of physical therapy as a rehabilitation service that takes place after an injury or surgery, studies and tests show that the exercises and programs that make up physical therapy treatment can be used as preventative measures that will train a person's body to be more prepared for the rigors of athletics. For instance, proprioception is used by trainers and coaches to reduce an athlete's reaction time to an adverse situation, which minimizes injuries such as ankle sprains and knee sprains. The less time it takes a football player to react to an oncoming tackler, the better his chances of avoiding a hit. And obviously, the lesser hits you take in a game, the less chance you have of being hurt. Physical therapy has demonstrated that through multi-directional agility training and proper stretching techniques, athletes can not only improve their strength and conditioning but also reduce the risk of injury, no matter what sport you participate in. From wrestling and swimming to track and field and boxing, your body undergoes intense physical strain, and the only way to prepare is through specific sports training programs that are designed to improve endurance, reaction time and agility.